JAWNS. Today my guest is Dr. Tom Mitros. Tom was a chief anesthesiologist in Pottstown, PA for many years before switching to a New York City hospital back in January. Tom is also the author of a popular COVID blog called Updates from the Front Lines. So Tom, I have a few questions for you related to your blog, which I've really been enjoying reading over the past few months. But I'd rather begin with this fateful decision you made to start practicing in New York City, of all places, back in January. Why don't you tell us how that came about to start off?
Sure, Chris, and thank you for inviting me to be a part of this presentation. So I sort of retired from active clinical practice in June of 2018 and wasn't really ready to stop doing everything. So I started doing some locums assignments, and I would go from surgery center to community hospital. I did a 10-week stint at Albany, which is a big academic tertiary care center. And fast forwarding to January of 2020, I wanted to go back and get into a hospital tertiary care setting. And so sometime in, I guess it was November, October, something like that, I accepted this assignment at the New York City Hospital. Before any of this stuff really hit. I mean, I guess by the time I started, because I started in the first week of January, news was out that something was going on, but I really didn't think much of it as it related to what I was doing.
Okay.
So
wow.
It was, I mean, fate is a good word to describe what ultimately happened. Yeah, for sure.
So the pandemic hits, New York City becomes quote unquote ground zero. How did the situation work out initially with you and your hospital?
So we saw this progressing, and it started out on the West Coast, and I happened to live in Pennsylvania, and oddly enough, in the county that I live in, we got hit pretty heavily because somebody had come back from Italy, and there was a quick flash of 13 people that got infected in our county, probably before New York was really getting hot, but we sort of knew it was coming, and I was concerned about the fact that I was reading about something called community transmission. And I thought that that this could pose a serious problem. Early on, there was data coming out of China about morbidity and mortality, then quickly followed by data from Italy. So we knew it was spreading rapidly. It didn't look like it was approaching the lethality of Ebola or SARS, but they weren't asymptomatic transmission. So the numbers were growing pretty rapidly in those places that were affected. And, it was obvious that, from the information coming out of China and Italy, that healthcare workers were going to be involved in this in a major way, and then things started to develop. There was 10 cases, there was 110 cases, there was 1,000 cases. And, we started talking about, I wasn't involved in the conversations, but obviously at a higher level, what are we going to do? Are we going to continue to do elective surgery? And a lot of things happened, pretty rapidly. And I want to preface all this by saying, we're still on a very, very steep learning curve about this virus. And so back in January, we knew practically nothing. Right. And then come February, we knew it was a problem, and we weren't sure at all how to deal with the problem. And that caused a lot of angst, by people who were paying attention. There were a lot of people that were just walking around thinking this was going to be nothing but a flu. And I didn't think so.
Okay, so let's get into
what happened. Ultimately was when it got hot at our hospital. So I would come home on weekends, and once it got hot, the chief called me up and said, "Look, I know this isn't what you signed up for, and if you want to, back out, with my blessing." And I said, "No, I think you guys are going to need a lot of help, and I'll be there."
So that's an amazing moment, and I'm really glad that you brought that up. The hospital gives you an out. You are already semi-retired at this point. What on earth made you stay on, knowing what was coming?
Well, so I only suspected what was coming. I didn't know what was coming. I felt that I was experienced. I thought that I would be able to deal with difficult situations better than younger people. I also felt that, I lived my life and these younger people were just starting. And I just thought I could be of assistance. I mean, it's, I don't think any healthcare worker signs up for this, but I mean, you do sign up to take care of sick people, right? And now we're going to have a lot of sick people. So how do you walk away from that?
Yeah, well, that's really, really commendable, Tom. Give us a sense, if you can, of what New York City hospitals were like once COVID really hit New York City. I'm curious what your day-to-day shifts would have been like before the pandemic and then after.
Yeah, so before the pandemic, we had normal visitors and nobody was running around with PPE, and certainly nobody was running around worried about catching some fatal disease in somebody's room. As things got closer and we started to see more and more patients with COVID, we started to get protocols together and PPE and all that kind of stuff. And then at our hospital, at least, it hit pretty rapidly. I mean, some major decisions were made. We cut out visitations. Everybody had to wear a mask. It was not negotiable. It didn't matter what your religion was or, what your civil liberties were. You were wearing a mask. You come into the hospital, you wear a mask all day long. You don't take it off. Then elective surgery stopped, and then we had to morph the hospital from a hospital that has maybe 10 to 20% of its beds in an acute critical care setting to that maybe went to 30 or 40% of its beds as critical care beds. And the ingenuity and the flexibility of our administration was remarkable. Prior to retiring, I'd spent the last 17 years of my career as a chief and/or an administrator. And so I had a decent amount of experience with administration, and I was impressed with how this administration was flexible and nimble and really paying attention to detail, trying to keep the angst in the staff down. But we went from the normal number of ICUs of any 300-bed hospital to, changing our PACU into an ICU. So we no longer had a post-anesthesia recovery unit. So we were recovering patients right in the OR. And so that slowed down the schedule, right? And, the one thing I remember feeling pretty impressed with was the fact that our surgeons didn't seem to bitch. I mean, these guys are used to, turnover, boom, boom, boom. Now they're, waiting an hour and a half or two. And honest to God, I mean, they really behaved. And I was, again, impressed with that behavior, and then we morphed our endoscopy unit, our burn unit, our cardiac catheterization unit into ICUs, and we, ran out of ventilators like everybody. We didn't run out, but we started getting, ventilators that like the military uses. And one of the other things that, so two things different for us, so we would on an average day, maybe do 1 or 2 intubations, when we got into the thick of it, we were doing anywhere from 20 to 35, 30 intubations a day. We had 2 intubation teams and 2 people on each team. And the other thing that you can't appreciate it if you haven't done it, you would go to a code, and you would just fly into the room, right? I mean, you just went right in. Not now. You know, now you go up to the floor outside the room and you got to get all the shit on, you know, and you know somebody's in there trying to die, you know, and it's like, wow, you know, but the thing is, if you don't, you know, we're all going to be not well. So who's going to take care of them? So it's really a very, very unique situation where, you know, somebody's trying to check out and you're out there putting all this crap on, you know, 2 masks, a hood, you know, gown and all this kind of stuff. And a different kind of a feeling, a different kind of a situation, you know, and then you're getting in there, you know, with a patient that is highly infective, doing what by then was known as a very, very, you know, potentially, you know, viral spreading procedure. And, you know, and you, especially early on, you don't know what you don't know. I mean, that's how bad it is. And, you know, the first couple times, I have to tell you, the sweat was going down my back. You know, I just was nervous. I didn't want anybody to see that I was nervous, especially I was sort of a senior citizen. You know, I'm older than all the staff that I'm working with. And they sort of are, you know, not in the beginning when they didn't know me that well, but as time went on, they sort of looked up to me as a, you know, been around the block, you know, watch what he does, you know, and being helpful. I can't let them see that I'm nervous. You know?
Yeah, of course. You've done hundreds of these, it sounds like, by now. Do you remember the very first one you performed on a known COVID patient? I mean, I just wonder what goes through your mind.
I did. I remember the very first one that I went to, you know, really, really.
What went through your mind as you were entering that room?
Well, it started in the hallway, right? Because I'm putting this stuff on and I don't get to see this guy, but I know that it's not good, you know, and go in with a team member and just really, really sick. And so I have 2 masks and I have a visor and I have a you know, a bunny suit on and, you know, 2 pairs of gloves. And I didn't want to breathe. But you can't make it through without it. And you just, you know, when it actually got time to, you know, here I am, I've got the bag over the patient's face and, you know, then rote took over, you know, because I've done, you know, what, 5,000, 10,000 intubations, you know, so this is just another one. The patient's different. The you know, the physical, you know, the procedure itself is 1 of 10,000. So do it. I mean, this is what you've learned how to do. This is what you're supposed to be better at than anybody else.
So that makes me wonder about coping strategies. It sounds like training kicks in at an important moment there and kind of carries you through. But then when you get back out of that room and all of this has been so stressful, so frankly scary, I'm just wondering how you feel like you and your team collectively have been coping through all of this for all of these months.
I think there were ups and downs for everybody, and I think that we sort of took part in helping each other. You know, took turns, and it was sort of therapeutic to talk somebody off the ledge. You know, it got you away from your angst and, you know, immersed into this person's, you know, and for a couple minutes, you got to forget about how nervous you were and just trying to help somebody. And, you know, that became the MO throughout this entire procedure, not only with people in the hospital that I was working with, but with other close friends of mine who had practices, and we're facing the challenges of how do I practice, you know, how do I set stuff up, and you know, some people really getting to the point that, you know, I've got 2 kids, you know, do I quit? And you know, if you need to leave, you need to leave, you know. That's your decision, you know. But you know, talking with those people and working through was a big part of what went on for months. I mean, to this day, I still, you know, I mean, I've had conversations almost every day with somebody talking about some aspect of this problem.
Yeah, and I can hear the emotion in your voice coming through there. And I really appreciate that notion you said of taking turns. It sounds like must have been an incredible bonding experience for you all, and remains so. All right, well, let's jump back to January again for a minute. I'm curious about the moment COVID first popped on your radar. Do you remember how far back that was? And what did you think as you were following this early news about Wuhan?
Yeah, so when I heard just like everybody else about the initial reports, and what has always been a big part of this pandemic experience is all the fake news and other bullshit that went on. So uh, uh, having to deal with the conspiracy theories and all this stuff, and some Chinese, viral weapon got out of control. Really, I don't think so. But uh, but I remember sometime in January, hearing about community transmission, and my understanding of community transmission is asymptomatic transmission. And that bothered me, and it bothered me enough that late in January I sent an email or text to my kids and a couple other friends and said, look, this is bothering me. I think you need to go out and get some masks. You need to get some gloves, and around 3 or 4 days later, I get a text from my son. What are we going to do with this stuff? I said, well, you're going to wear it, 3 or 4 days later. Well, when are we going to wear it? I said, I'll let you know. We sort of left it at that. And then, as I was talking to people, and I started reading, I've always been a fairly avid reader. And, being away, I don't have anything to do. I'm in a hotel room, and I just started reading every night. And, in the beginning, there wasn't that much to read, right? I mean, it's not like there's 1,000 people writing 1,000 articles on this thing, because nobody knew, right? It wasn't until, it, got over to Italy that you really started to have more stuff to read. And then, a couple months later, China started doing some really nice publications on their experience with all of this. So in the beginning, it was pretty easy to keep up with the literature because there just wasn't that much. And I was just reading all I could get my hands on. And by February, I was convinced that we really should be wearing masks. And so when I went to the hospital, I wore 2. I thought if 1 is good, 2 is better. So I wore a regular surgical mask, and then I put a mask with a visor on top of that. And I wore that all day. And I really couldn't understand why like the CDC was saying masks aren't going to help. And I'm thought, bullshit, masks are going to help. I mean, are they going to be perfect? Nah, not going to be perfect. Nothing's perfect. But are they going to help? For sure. There's no doubt in my mind that they're going to help. And I would get this, well, you think you know more than the CDC? Absolutely not. I don't. I'll tell you today, I would have told you back in January, I don't. But I felt that they just were getting this wrong. I couldn't tell you why they were getting this wrong, but I felt they were getting it wrong.
Yeah. So I want to connect a couple points you made. We'll circle back to the CDC in a second. But a moment ago, you mentioned in relation to your colleagues that if they had family responsibilities or family situations that could pull them away from work, that you would respect that and, of course, understand it.
Absolutely.
Now, back in January, you're warning your family in no uncertain terms. Stock up, guys. Get ready. I'll let you know. I'll sound the horn when I need to. But then at the same time, your family knows that you're heading, therefore, into a very dangerous situation. Did that create tensions at home, if that's not too personal of a question?
No tension. Certainly concerns. I appreciated that my kids were worried.
Mm. Did they ask you not to go at any point? Did they ask you to, did they wish you would retire? Were you put in a situation where you had to make a very tough call?
They wanted to know, they didn't tell me not to go. They didn't understand why I felt the need to go.
Wow. Okay.
They both said, you've done enough.
Yeah. All right, well, let's get into your blog a bit now. I love it. It's informative, but it's also irreverent. It has that same sense of humor that I'm getting from you here today. And I've appreciated throughout reading through it over the past few months that you have not been afraid whatsoever to take critical stances. You've already mentioned the issue of masks with the CDC and this early misinformation that was disseminated about their effectiveness. What else have you seen from either the CDC or the FDA that you'd want to share thoughts on over the past 6 months, decisions they've made that you've approved of or disapproved of? How do you think they've been handling all of this?
Yeah. Before I answer that, let me step back. So the origin of the blog was really emails, and what and the feedback from the emails, because I started getting questions, like, well, how do we shop? How do we come into the house? I thought, all good questions. I mean, I know. So one of my earliest emails was like, here's what you do, guys. When you go to a place like a grocery store, for instance, you bring all your shit home and you wipe it all down, and then you get undressed in the laundry room or in the garage and you go up and you take a shower, and don't touch anything, or, and then as we learned, this evolved, so like, a couple weeks or a month after that, I write back and say, look, you don't have to wipe all this shit down anymore. Just leave it in the garage for a couple of days, because this virus is not, hardy. This thing loses its infectivity pretty quickly, depending on what it was on. So it was stuff like that. And then, so I would send out an email, and unbeknownst to me, the people that were getting it would send it out to somebody. And then I would get this email, can you put me on your email list? And that went on till I had like around 100 people on my email list, and and they were all sending it out to other people, and then I started encouraging them to send it out, and then my son said to me, you ought to make a blog. And I said, I don't know anything from blog. He said, look, we'll do it. He said, a couple of my friends just think this is great. So you continue to do what you do, and we're going to put it into a blog. And that's how it sort of evolved. And then I felt it was, so I'm getting a lot of questions about, ridiculous stuff. So I remember this one in particular. There was an article in JAMA about proning, taking care of patients in the prone position, and there was a study from the ER that talked about, the beneficial effect of proning and how some of the patients, didn't need to end up getting intubated because of it. Didn't talk at all about death, right? Didn't follow these patients out of the ER. And a day later, there's headlines, proning saves lives. I thought, this is bullshit. That study didn't have anything to do with it. And there was just one example after another like that. So I spent a lot of my time just correcting the lay interpretation of medical information. And then there were the issues of the CDC and the FDA, and like, how are they getting it wrong? And, so I'm sending out an email since, late January or early February. And, it's been read now by thousands of people. And then all of a sudden the CDC says you should start wearing masks. And I'm getting all these, you were right. Like, I'm a prophet. I'm not a prophet. I don't know what happened, and at the time, politics and politicization of the pandemic didn't occur to me. But I mean, have I been critical? Yeah, the CDC was behind the eight ball. I don't, our response to the pandemic was not good. The hospital that I worked at, we had all the PPE that we needed. I don't know how they did it. I don't know what trucks they were breaking into, but I mean, it wasn't like the other New York hospitals. And I saw the pictures of nurses walking around in garbage bags. That wasn't us. I mean, and my kids would say, do you have enough PPE? We're swimming in it.
Yeah,
I'm not doing anything unsafe because I don't have the proper equipment. And then, with the, the FDA and the emergency use authorization. I think that's been just a total fiasco, and I have no idea what they're thinking or what they're doing. I mean, you're looking at a situation where if we had invested in the science of persuasion and gotten people to embrace wearing masks and distancing, we wouldn't be in this muddle. And the other thing is, historically, emergency use authorization. I've been a physician for a long time. I was a clinical pharmacist before I went into medicine. I've seen this. It's usually reserved for those situations where you have a patient or a type of patient that is going to reach a terminal stage and there are no other treatments. And now you get this emergency use authorization. And most of the time they were products that were on the market and now you're just repurposing them, right? That was the typical history of an EUA. Well, in this situation, we have an alternative, right? Wear mask and distance. That's the alternative. How about we start dealing with that, and then, these, some of them are repurposed, some of them are new. So, the hydroxychloroquine was a total fiasco. Who the hell didn't know that shit didn't work? It didn't.
Yeah.
There was no study to prove that it worked. So why are we doing an EUA? And I'm getting emails from guys asking me about this, and they're telling me about this guy from Harvard. And I don't care, Harvard, Yale, whatever. I'm looking at the data. I can look at data just as well as anybody else. So if somebody wants to come and sit with me and argue or debate the data, I'm up for it. And I don't care where they come from, but the data wasn't there, and then, so let's
give us a couple more examples. I know you have
remdesivir. Let's talk about remdesivir.
Yeah.
Here's another one. So the FDA gives remdesivir an EUA back in May. Now, when they issued this EUA, there were 2 randomized controlled trials out. One from China, which showed it didn't work, and the other one that showed that there was an improvement, that it shortened hospitalization, but no death benefit. Open label, okay? Open label. And now, just this past week, another one came out, a larger study looking at 5 days of remdesivir, 10 days of remdesivir versus standard of care. Open label. And the 10-day course didn't work. So the 5-day course worked. Why didn't the 10-day course work? Question number 1. Number 2, the authors of this paper, come out and say that there is, clinical improvement of unknown importance.
Yeah.
They're not even trying to say. And here's the other thing that I looked at, early on, there were studies that came out, especially from China and South Korea, that couldn't get that, after 9 days or 10 days, you couldn't culture virus anymore. So there was no live virus anymore in circulating. So this is a disease where the virus comes in and plays havoc for, 5 to 10 days. And then your immune system takes over and everything else we see is a result of what the virus has done in triggering our immune system. But you're no longer fighting virus on day 11. You're fighting the immune response that the virus has triggered. So both of these studies, the median entry into the study was day 9. Well, there's not supposed to be a lot of virus. So why would it work anyway? I wouldn't expect remdesivir to work if we're giving it to people at day 9. One of the earlier studies with convalescent therapy didn't start until day 28. Well, I don't think it's going to work then. Because for sure, by then, nobody's dealing with live virus. So those studies were doomed to failure.
So one clarification question in there for non-medical professionals, which is most of my audience. You referred to these studies being problematic because they were open label. Can you explain what that means and why that's important?
So, as opposed to a double-blind study where the participants running the study don't know who got what. So you eliminate that bias in interpretation, right?
Mm-hmm.
These were open label. Everybody knew, who got what. And one of the studies sort of said, well, it was open label because we couldn't get placebo vials. And I'm thinking, seriously, you couldn't get placebo vials? You have all this high-tech stuff, and you're telling me that you couldn't come up with 5,000 placebo vials. I don't buy it.
Yeah, that sounds a little suspicious too.
Well, I mean, it's ridiculous.
What about plasma therapy? I mean, I'm getting the sense that you're not very persuaded by any of these treatments yet, that we definitely don't have any kind of magic bullet. Do you think plasma therapy can be effective?
I think, you have, when you're going to do antiviral treatment, you need to start the treatment at a time when virus is causing the disease, right? So I think that there may be a role for convalescent plasma therapy, but you're going to need to start it early on, and the problem with that, if you can appreciate this, is the fact that early on, you don't know who's going to get sick, right? Or if you do know who's going to get sick, you sure as hell don't know who's going to get really sick. So contrast that with, say, something like monoclonal antibodies, where, hey, do I mind giving monoclonal antibodies prophylactically? Not at all. When can we start? When can one of these pharmaceutical companies come out with monoclonals, that have been shown to be, effective, and let's start using them. And the other thing that's nice about a monoclonal is that, you have somebody that's day 4 or 5 into their disease, you give a monoclonal and you don't have to wait for seroconversion. You don't have to wait for the body's immune system to start doing its thing, right? You're giving it the thing, so you could get to somebody, in day 5 who's, looking like he might get ill, give them monoclonals, and you're still within that window where you expect virus to continue to create havoc. So the differences.
Okay.
I give, if you're going to give an antimicrobial, I sure would like to know we got bacteria. No sense giving somebody an antimicrobial if they don't have any bacteria.
Yeah.
What are we treating?
All right. Well, let's broaden things out a little bit. We're talk about the national scene. We're both from Pennsylvania. We're both Eagles fans. There's been a lot of debate over whether we should be holding sporting events right now, either professional or collegiate. I know you've posted about this a few times on the blog as well. From a health perspective, do you think it is safe to be holding these kinds of events yet?
So as a clinician, and I can't divorce myself from what I've seen, and I know that what I've seen is obviously skewed, like my kids can't appreciate what I've seen, and if I don't see another person die from COVID, that'll be too many. In a 4-month period of time, within 48 hours of an anesthetic that I gave, I lost more people than I did in 30 years prior. So I am not in favor of anything that is going to increase the disease burden and have one more person get really sick. Now, having said that, I think it's marvelous what the NBA and the NHL did, bubbling, making sure that when you get into the environment that you're disease free and you stay in the bubble, and, this isn't magic, this virus has to get carried on somebody's respiratory secretion. And if you don't have somebody with viral laden respiratory secretion, you're not getting infected. This is not the immaculate infection. That's not it.
Yeah.
So I think that that's great. I think that it was hard, if not impossible, obviously, to do with football. I think the baseball players, I don't know what planet they were living on, especially initially just going out and doing whatever the hell they wanted and then coming back with all kinds of problems. But I think, let's take football, where you have close body contact, you're tackling, you're coughing into each other's faces. There's no way to make that safe. There's safer, for a professional who's making his livelihood that way, and they're being tested every day, and they're willing to accept the risk of safer. And I have a problem with this. I mean, I'm not necessarily 100% sold on this, but I see it, but to go to high school, especially high school, I think they're crazy. You're not protecting those kids. There's no way to protect those kids. You're not testing them every day. And, we're learning stuff, right? So there was a report out not too long ago, 10 days ago, I put it in one of my Sunday blogs, that, a large percentage of Big Ten players who were infected, who were then followed up by, cardiac evaluation, a large percentage of them had myocarditis, so 20, 30 years from now, are we going to have a bunch of people walking around with defibrillators because they've got arrhythmias from scarring from myocarditis? I mean, we don't know. I mean, for everybody to glibly say that this is safe, it's not safe. It's not even safer. You don't know. We don't know.
But Tom, they're young. I thought they couldn't get serious health complications.
I think below 10, you can't. Or it's extremely rare. But I mean, there was an article out last week in JAMA Pediatrics about 10% of the. I think it was 10% of the pediatric population that presented to pediatric hospitals ended up having COVID, and 2.7% of them died. So, and not all of them had comorbidities. I mean, I reported it last Sunday, the kid from, University of California, Pennsylvania, 20-year-old kid, healthy, no comorbidities, large. I think large people are at much more risk than normally built people, died. And his parents, followed up with some interviews and said, look, if your kid's playing football, don't let him. And I think you're right. I mean, so statistics, 1%, you got 100 body parts. 1% doesn't mean that I take one of your body parts. For that 1%, it's totally fatal. You're dead. It's not like I can take 100 body parts from everybody and that's not the way it works. For one person, it's 100%. And, who wants that? I was looking at the Challenger thing. Yeah, there's a documentary in the Challenger. Yeah. I mean, who expects that, right? I mean, tragic. You're watching your daughter die. Certainly didn't expect it.
Yeah, it's weird you bring that up. I was watching that last night myself as well. Well, Tom, one last question for you. You saw where this was all headed, so I think you do get a lot of profit points. You saw this very early, and you put yourself in harm's way to help, and I want to commend you again for that. Last question I want to ask is, I'm wondering what you think the future of healthcare looks like. Do you foresee the pandemic causing any really big changes to the profession?
Yeah, I mean, they're not all bad. I mean, so a lot of good systems have been developed because of this, right? Learning how to, I mean, we're always at risk for communicable diseases. I don't think that this is the last time we're going to deal with something like this. There's a flu season coming up. Maybe, we'll have more people wear masks and distance this flu season than ever before. And so maybe flu season will be small. Certainly telemedicine has really jumped into the forefront of how we're dealing with things. The downside is I think a lot of people aren't making medical contacts when they should because they're afraid to go to hospital settings. So it's a mixed bag and message about what's going on. But I think the most important thing is that, like a lot of people, bright people have said, I mean, we should be learning from history, we should be learning from our errors, and learning from the things that we did right too, right? I mean, so I've worked with two practices, helping them sort of, from the time that they stopped seeing patients and started gearing up for a return to seeing patients. And I think that one of the real benefits to coming up with protocols was the fact that when I talk to these people, they're more at ease than other folks that I talk to because I think they implemented protocols and there was a science behind it, and they were really good about going to their staff and explaining and comforting their staff and saying, look, you know, we're going to be safe. We're not going to deviate from this. This is what we're going to do every day. And it worked, you know, and I think that's a great thing. And I think everybody, you know, I think people that have done that are going to learn from that. And, you know, I've seen people become leaders when the folks around them were floundering, step up to the plate, take charge. I mean, so there's been a lot of positive things come out of this.
Yeah, great. All right, Tom. Well, thanks again for coming on the show. Thank you for all you've done.
Thank you for having me.
Go Birds.
Yep. Go Birds.